Okay.
I'm ready.
So I'm Julie. I work with Fisher and Paykel. So I'm here today to talk about Flexi Trunk, how to size, the importance of sizing, because it's super important to take your time and size appropriately with the mask and the prongs. And then we're also going to talk a little bit about Baby Liv, which is a sim doll that I have. This is a 28-week CD mapped airway that has a pressure manometer. So I can show you guys the difference in pressures being delivered with Flexi Trunk versus the cannula. So to get started, when the doctor orders Flexi Trunk, the first thing you're going to determine is the bonnet size, and it goes by head circumference. We have 4 different sizes. The 17 to 22 is obviously for your smaller babies, your micro preemies. The next size up is 22 to 25 cms. We have a 25 to 29 cms, and then 29 to 36 for your larger term kids. And I always tell folks, if the baby's kind of in between sizes, size down, because this is knit, it's going to stretch out. Much better to have a nice snug bonnet than one that is loose and moving everywhere, because then all this is going to move as well. So this is kind of like your foundation. You want a solid, tight foundation, and then your Flexi Trunk builds on top of that. I was at a hospital a few months ago, and the RT measured the baby's head circumference to be 26 cms. So she used this bonnet, the 22 to 25, or the 25 to 29, but ended up going down to the 22 to 25. So if you're right there at the cusp, definitely size down. And don't be afraid to change the bonnet out every few days, because like I said, it is going to stretch out. I've had this one for a couple of months probably now, and it's very stretched out, but definitely, every 2 to 3 days, you probably will be changing out your bonnet. As far as placement, it needs to be brow level, over the ears, and down to the nape of the neck. So if you ever go in and notice the baby's little earlobes poking out, make sure we pull it down, make sure the ears are not folded forward, just keep it nice and secure. This little opening back here, what that's for is for the IV tubing to run out the back if they happen to have an IV in their head. But don't feel like you have to tie this up tight. I would not tie it up at all, because all that's going to do is put tension on the bonnet and make it slide up. So honestly, if you want to snip these little strings off, you're no problem. Go ahead and snip them off. We don't have to worry about the babies losing head through the hat, because you have them in your giraffes. You have, radiant heat warmers, so no need to worry about tying that up tight, because they're not going to lose any heat. So from here, we'll determine the nasal tubing sizes. I know currently you guys have the small, but we do have a couple other sizes I'm going to show you. The smallest size we have is the 50 cms. And the way that you measure for the nasal tubing, this hard plastic piece from here to here, not the corrugated part, but this hard piece here needs to go tip of the nose to top of the head. So you would see here, this would be a little too small for this baby. And when you have a nasal tubing that's too small, what you're going to find is with the prongs, you're not going to have enough room here. It's going to pull those prongs into the baby's nose if it's a little too small for the baby, or make the mask, flatten out more. You're just not going to have a lot of room to work with. So this, honestly, the 50 millimeter is going to be more like your 25, 26 weeker, maybe 27, just depends on the size of the baby. The next size up is the 70 millimeter, and that's probably the more common size that is used. That's what I would use for this little girl here, tip of the nose, top of the head. So this is what helps keep everything nice, parallel, midline, keeps the mask or the prongs in place. And then we have a 100, which is going to be more like your term kids, your larger kids, obviously, a larger head. So when you first take it out of the packaging, you'll have these adapter pieces. You're not going to need these. You can hold on to them, but they come off. Your inspiratory and expiratory limb from either your bubble CPAP or your vent circuit are going to hook up directly here. And you'll notice we have this crinkly material. This is called Evaqua material. So your last temperature probe on your circuit sits right here. So you do have a little bit of dead space there. So what that Evaqua material is what it does is if you have condensate collect in this area, it's going to evaporate. So it's not going to collect and dump into your baby and lavage them. So that's what that's for. You'll still see some beading in this area, which you want to. You don't want it to be dry air going into the baby, but it's not going to collect and dump into the baby and cause A's and B's. Now in our nasal tubing package, we just have the nasal tubing, and then you have your sizing guide. So one comes in each package. So we don't pre-package mask or prongs in our packaging. We want you to size your baby, then you go pick whatever size mask or prongs you need. We package our mask and prongs in these little packs like this. So when you're sizing, you'll notice we have 4 different size masks and 11 different size prongs, and people ask, why do you have so many prongs? It's because we do want to custom fit the prong to the baby. We don't want to have to use NeoSeal, cannulate, any of that ooey gooey stuff to make something work. We want to fit the prong to the baby, and that means you have to hold the sizing guide up to the baby. You can't just eyeball them. If you eyeball them, you're always going to size too small. I guarantee it. So we're going to use this little creepy doll here to do the sizing. This has a little bit more lifelike skin. And looking at this doll, you may think, that's a really small nose. I bet it needs a small mask. But when I hold the sizing guide up, you see that small mask would be too small. Because the nose, any movement of the baby and that mask is going to be putting pressure on the nares or the bottom of the septum. So I will go more for a medium. You might even can do a large. You don't want the mask blowing the baby's eyes or dropping down into the mouth, but you definitely want to be sure that that nose is completely inside the white border. Now with the prongs, this is pressure therapy. It's not like a cannula where you want to see gaps. You want to make sure those white dots completely occlude the nares, but you also do not want the septum being squeezed. And that 30-20 prong, that would be entirely too small. You see gaps and the septum's getting squeezed. 35-20, a little better, but I'm still seeing some gaps. So the 40-30 would be the best fit for this baby. And this is a 40-30 right here, just to kind of show you how it would look. Obviously it would be attached to the nasal tubing, but there's a nice anatomical shape. It has that curvature. So whenever it goes into the baby's nose, if it's hanging out halfway like that, that's completely fine. It's not moving. It's not going up and down, causing friction, causing breakdown. And it does not need to go all the way in. If the prongs are sliding all the way in, they're too small. So don't be alarmed if they're hanging out a little bit. That's completely fine. And with the mask, you'll notice there's a clear area and a frosted area. So if you ever see your mask and all you see is clear or it looks like a pancake, those straps are too tight. So the mask should always look like a little bubble. It should never look like a pancake. So when it looks like a pancake, you're going to get pressure on the bridge of the nose and on the upper lip. So from here, just to show you the difference between the mask and the prongs. With the mask, it just fits on the inside of the interface like that. Pretty easy. The prongs are going to fit on the outside of the interface. So if you ever have issues trying to line up the prong just right and get it to slide on there like that, what you can do is you squeeze the sides inward to expose that little ridge, and then you can feed it on from one side to the other, just like that. We'll go ahead and place the prongs in the baby's nose. This gray block, it does move. It needs to be between the eyes, but on the forehead. And then you just Velcro that down. And then you have the white D-ring, which goes under the blue glider piece. And then it Velcros down. So you just have one strap on either side. Now with those straps, with the little Velcro dots, they really should be ear level, maybe a little bit beyond the ear. But if you ever find you're having to put the straps back behind the baby's head, we need to be thinking, are the straps too tight? Is the bonnet stretched out, needs to be changed, or maybe is the bonnet just too big? You really should not have to strap those straps back behind the baby's head. And you see how there is a gap here. The prongs are not flush against the baby's nose. They should never be touching the baby's septum. And from here, you can go sideline with the babies. You can go prone. Parents can hold, and it's going to stay in place. You do want it to stay nice in midline. So I'm going to go ahead and attach to the bubbler. Turn my flow on. So what I'm listening for is that nice, gentle bubbling. You know, if you lose your bubble, you need to be thinking, I've got a leak. So this is pressure therapy. If we have a leak, we're gonna lose our bubble, we're gonna lose our pressure. So if you do lose your bubble, you would wanna start at your baby and work your way back. 98% of the time, it's gonna be something with the interface. Either the prongs need to be readjusted, maybe the mask is cocked to one side, it has a leak. Make sure the bonnet is in the correct position. There's a little port right here, make sure it's capped. Make sure your temperature probes are nice and tight. There's also a port back here, make sure it's capped. But you may run into this scenario when you have babies that keep their mouth wide open. Most 28, 27 weekers are not gonna hold a pacifier. So in those scenarios, we do recommend a chin strap. So we do have 4 different size chin straps. They go by facial circumference. And what these do, they are not meant to completely close the baby's chin. It's just meant to splint the chin. And the way that we apply the chin strap, it's just under the, we have 2 Velcro strap. One is gonna go on the front, on the top of the head, and the other strap goes back on the crown of the head. And it just will Velcro back there. So, and that's just for those babies that have their mouth wide open and there's nothing we can do. We've repositioned. We're constantly having to go in there, try to get our bubble back, irritating the baby. In those scenarios, the chin strap is definitely going to be a lifesaver for you and for the patient. So from here, I do want to show the difference in pressures being delivered with a true FlexiTrunk sealed interface versus a cannula. And just a couple things you'll notice with FlexiTrunk, it's the same diameter as your dual limb circuit. So low resistance here, baby inhales, exhales, everything's happening here at the baby. When we start putting cannulas on, then you don't have a lot of gas exchange till we're back beyond the Y, and I'll show that to you in just a minute. So let's get baby Liv, turn her on here. So I have my CPAP set at 5 down here on my bubbler. I'm gonna attach my FlexiTrunk with a mask. First thing you'll notice, we have no bubbling because I have a leak. So that's my indication. Let me go check on my baby. As soon as I occlude that mask and get a good seal, I have my bubbling. So on here, your pressure reading is going to be right there in that corner. So I'm going to pull this closer. So we'll see here. I'm getting 4.8, 4.3. You get those nice pressure oscillations, which that's what you want with bubble. That helps recruit the alveoli, helps establish FRC, helps decrease work of breathing, and you do get a little bit of chest wiggle. It's not like an oscillator, but you do get some wiggle there. Take the pacifier out. I don't have my bubble, that's my indication. Let me go check on my baby because I have a leak. Now when I start putting cannulas on, one thing you'll notice right off the bat is it's on here. Is it bubbles no matter what, because you have all that resistance. So you have this dual limb circuit, you know, cushion and flow, one direction to this narrow, skinny cannula, and you're getting that back pressure. So it doesn't matter, this could be laying on the floor and it's gonna bubble. So you don't have that same comfort knowing, listening for the bubble or listening for your vent alarm, because with the cannula on the vent or on the bubbler, it's never gonna alarm because it has all that back pressure. When I place it in the baby, put the pacifier back in. Even though I have this great bubbling effect going on back here, everything sounds great, I'm only getting 1.3, maybe 1.5 at best of pressure. Now if I take the pacifier out, it drops down to 0.2, 0.3. Now I can increase my CPAP pressure back here. Let's just go ahead and put it down to 8. And even at 8, I might be getting 2. So even if you increase your settings, you're still really not getting much pressure delivery. So it's a good eye opener for you to see the differences in pressures being delivered with a cannula versus a true sealed interface. You know, the biggest takeaway is definitely, I would hate to hear if you guys or anybody intubating off of this setup, at least try, you know, rescue the baby, give them a chance on a true sealed interface before you intubate. And all of the latest studies do show like 32 and less needs pressure, not flow. Typically 32, 33 weeks are going to be okay on a flow-based therapy on a cannula, but those small babies really need true pressure to help their lungs develop. So that's the reason, the labor of love that we have for the Flexi Trunk. I know it's more steps, it's, you know, more work, but that, especially with these smaller babies, that's definitely what they need to help. So
Okay.
okay.
All right. Thank you, Julie. I
Thank
appreciate
you.
it.